I'm Dilip Jose, Managing Director and CEO of Manipal Hospitals. The rationale for this acquisition of both Columbia Asia and Vikram was two or three key areas to be covered. One, of course, was expand our footprint to much larger areas in the country, that expand the geography that we cover, expand the patient base that we cover. So between these two acquisitions, we have now reached 28 hospitals and covering 14 cities. So that is the first rationale of both these transactions. Secondly, of course, the core to this transaction, both these transactions were the people, that both Columbia Asia and Vikram had highly trained clinical teams, very good nurses and technicians, and a very good management team. So when such a large team comes together along with the original team at Manipal Hospitals, we are able to sort of leverage this extensive clinical team across the network. For example, somebody who was only practicing in Manipal earlier or only in Columbia Asia earlier, those clinicians can now practice across the integrated network of 28 hospitals. So people can access their skills, whether in oncology, organ transplant, complicated niche kind of procedures. Now we are able to reach it to the patient across a much wider geography. That is the second element. Third, of course, is with the scale comes a lot of synergies, and whether it is in terms of our ability to procure better, our ability to leverage the talent that we have on the management side better. So those synergies are also available. So this larger platform, larger network is actually helping us use our team better, our clinical team better, our management skill set better, at the same time catering to a much wider audience. Major learning from the pandemic was the need for the hospitals to be adaptable. That when COVID hit us, the need for different kind of beds, oxygen beds, HDU beds, ICU beds, this went up to begin with, then they fluctuated. Different people require different kind of treatment and therefore support infrastructure. So one key learning, of course, is a hospital to be adaptable and flexible. We cannot in the future have a hardwired kind of a facility where we say out of 300 hospital beds, 100 or 50 are ICU beds. I think people would have to have infrastructure which is fungible, which can function as high dependency or ICU beds sometime, go back to normal beds later. I think that is one adaptability that is required. That is one. Secondly, the digital capabilities that hospitals should have. Given that social distancing and other needs will continue for the future, people may not want to travel long distances for healthcare. So digital routes to access healthcare is something that hospitals will have to factor in, either by retrofitting whenever required or factoring in the design when you construct new hospitals. So that digital routes and digital adaptability is something that you would require. These two are two key learnings. And the third, of course, is for multidisciplinary teams to function. That what COVID also taught us is that different specialities had to come together. Particularly, it was an unknown virus. Different specialities had to come together to battle it. So even in design of facilities in the future, we would have to have fungibility between specialities, ability for doctors to come together and work. So these 3-4 learnings are what we should carry home from an infrastructure perspective. One, of course, is we had ensured that we converted all our hospital beds with oxygen supplies. That we do not have a situation where oxygen supply is not available to any bed. So that is one thing that we were able to do. We were able to create isolation rooms, temporary isolation rooms, create temporary negative pressure kind of engineering solutions we were able to do. Third, of course, was creating additional ICU beds or HDU beds in a short time. So these are 3-4 things that we could do. We were also able to run temporary hospital outside of our facilities. When the second wave peak hit us, we had run out of beds completely. We could convert other non-hospital kind of spaces, whether hotels or other kind of spaces, into clinical areas. So these are again some of the examples from within Manipal that I could tell you. We would, as Manipal Hospital, want to build on the current strength that I explained to you earlier, the 28 hospitals and 7,300 beds that we have. we would want to expand to newer territories, either to cover a fresh area or go deeper into a geography we are already present. For example, Kerala is a market, a territory that we are keenly interested in, because an adjacent territory to Karnataka where we are present in high strength. Similarly, Andhra Pradesh, we have a hospital in Vijayawada. We would want to be there in Vizag. We would want to be there in Hyderabad. These are markets that we would look at as fresh territories. The second option that I talked about is going deeper in a place where we are already present. NCR, where we have 3 hospitals, we would want to have at least 2 more facilities in NCR. Kolkata, where we have 1 facility now, we would want to expand our presence. So these are some of the markets or territories of importance for us, and we would work to getting our presence enhanced in those places.